third session of our Lunch and Learn series, Centering the Child. Not exactly a lunch and learn this morning, but please feel free to have your morning tea with this session if you like. I'm Emma Nugent, Project Officer at the Centre for Excellence in Child and Family Welfare. Today we're exploring how the Child and Information Sharing Schemes, Family Violence Information Sharing Scheme, and the MARAM Framework are transforming collaborative practice across care teams. But before we get into today's topic, I'd like to acknowledge the traditional custodians of the lands on which we meet. The Centre for Excellence in Child and Family Welfare would like to acknowledge and pay respect to the past and present traditional custodians and elders of this country on which we work. We also acknowledge the injustices and trauma suffered as a result of European settlement, including the stolen generations and forced removal of children. We honour and respect the resilience of Aboriginal and Torres Strait Islander communities and the ongoing aspirations for self-determination and empowerment. I'm pleased to be continuing our Centering the Child series today. So this 4-part series is designed to support practitioners in aligning their practice with the MARAM framework, particularly when working with children and young people impacted by family violence. We know that children are victim survivors in their own right, and that the experiences of family violence can significantly affect the development, emotional well-being, and sense of safety. As I mentioned earlier, today's session will explore how the information sharing schemes and the MARAM framework are transforming collaborative practice across care teams. We'll focus on MARAM Responsibilities 5 and 6, which support practitioners to seek consultation, contribute to risk assessment, and share information effectively while maintaining trust and confidentiality. We'll be using Hayley's case scenario to guide our discussion. Her story reflects the complex realities children face in family violence contexts and will help us explore how to respond in ways that are trauma-informed, developmentally appropriate, and collaborative. This is the third of 4 sessions in the series. In our first and second sessions, we explored how trauma impacts child development, attachment, and how to include children's voices in risk assessment and safety planning. Today, we'll build on that by focusing on how to embed purposeful, child-focused information sharing across care teams. In today's session, we'll be building on previous discussions about trauma development and child-inclusive practice. Our objectives are to understand how Responsibilities 5 and 6 under the MARAM framework support collaborative risk assessment and management across care teams, identify what purposeful child-focused information sharing looks like in practice and how it can be embedded into everyday decision-making and care planning, and reflect on how information sharing can empower children and promote long-term safety while balancing confidentiality and consent. We'll also look at exploring strategies for building and maintaining trust with children, families, and other professionals while fulfilling obligations under the information sharing schemes, as well as recognizing the importance of role clarity and communication pathways when multiple practitioners are involved in supporting a child or family. Let's take a moment to highlight the 2 foundational responsibilities under the MARAM framework which underpin today's session. The Responsibility 5, which is seek consultation for comprehensive risk assessment, risk management, and referrals. CISS practitioners are required to seek consultation and share relevant information to inform risk assessment and management. This includes sharing proactively with other services when there is a legitimate purpose and ensuring that information is accurate, timely, and purposeful. Practitioners must also consider how to maintain trust and transparency with clients, especially children and young people, when sharing information. Responsibility 6, contribute to information sharing with other services. With this responsibility, practitioners must contribute to risk assessments when requested by another service and provide relevant information that helps build a complete picture of risk. This includes recognizing patterns of harm, understanding the child's lived experience, and collaborating across services to ensure that assessments are holistic and child-focused. Practitioners should also be aware of the barriers to effective collaboration, such as unclear roles, inconsistent communication, or concerns about confidentiality. Together, these responsibilities support a culture of coordinated child-centered practice, where information is shared purposefully to protect children and promote recovery. So just a quick note on housekeeping before we dive into today's session. So today's session is being recorded. Audience members' microphones and cameras will remain off by default for the duration of today's session. If you experience any technical issues, please try exiting and rejoining. If not, I'm also monitoring the chat box and can assist audience members if needed. If you have any reflections or questions for today's panelists, please use the question and answer box or use the chat function as needed. Also noting that some of today's content may be distressing, so please take care when listening and engaging, and please reach out to the support services listed in today's chat if you have any concerns that come up for you or others. I'll just pop those in the chat for you. So today we encourage you to engage actively in today's session. Share your questions, reflections, and experiences in the chat. Please note that this is a space for learning, connection, and strengthening practice together. Thank you for being here, and let's take a look at today's case scenario. So you should have all received a copy of the case scenario this morning before our session, but we will go through the case anyway to ensure that everyone is on the same page. So Hayley's story will guide our discussion today. Her experiences reflect the complex realities children face in the family violence context. And let me introduce you to Hayley. So Hayley is 12 years old and lives with her parents on a dairy farm. She attends a small local primary school, and recently she's noticed increased conflict between her parents, especially around financial stress. Hayley is experiencing anxiety, poor sleep, and emotional distress. Her story reflects the complex realities children face in family violence contexts. Hayley's father has been drinking more and becomes angry and aggressive when intoxicated. Hayley has witnessed yelling and property damage during arguments. She feels responsible for her mother's well-being and has avoided school to stay home. When police visited, she downplayed her fear to protect her father. Hayley's mother confided in a friend about the escalating violence and her own emotional struggles. She's experiencing symptoms of depression and feeling overwhelmed. Hayley hopes someone can help her family. Let's take a closer look at Hayley's profile. So Hayley is in year 6 and experiencing school can't. She has anxiety, irregular sleep, and psychosomatic complaints. She's at risk of depression if support isn't accessed. Her interests have faded and she spends time alone on her iPad. She is deeply affected by her mother's distress and wants to help. Now to Hayley's mum. Hayley's mum is emotionally overwhelmed and experiencing coercive control. She shows signs of depression and trauma responses like hypervigilance and avoidance. She has limited social support and needs mental health support, safety planning, peer connection, and a GP assessment and possible referral to public mental health services. Hayley's father is showing signs of significant distress and behavioural concerns. His alcohol use has increased and he has become impulsive and angry when drinking. He may be experiencing depression or anxiety as suggested by irritability and hopelessness about the farm and finances. He's defensive and ambivalent about seeking help, which is common in cases involving shame or denial. He needs a multi-pronged support approach. This could look like AOD intervention, addressing use of family violence, anger management, as well as mental health assessment with potential referral to public services if risk escalates. Understanding the dynamics between Hayley's parents is crucial for assessing risk and planning interventions that centre the child's safety and well-being. So for today's discussion, we're joined by a diverse panel of expert practitioners who will share insights and strategies from their work across family violence, mental health, AOD, and child and family services. Each brings a unique lens to the challenges and opportunities of collaborative and child-focused practice. So our panelists will help us unpack key concepts from Hayley's case scenario and explore how the information sharing schemes and MARAM Responsibilities 5 and 6 can be applied in real-world settings to support children's safety and well-being. Let me stop sharing my screen so you can see their faces. I'll just spotlight them quickly, and then we'll get into our chat. Amazing. So first of all, we have Meg Bagnall. So Meg is the lead AOD and family violence advisor at BARDA. So Meg holds a Bachelor of Psychological Science complemented by a Master's in Politics and Policy with a career spanning over a decade in and around the family violence sector. So Meg brings a wealth of experience and expertise to BARDA. Meg is passionate about improving community outcomes and employs a compassionate, collaborative and cooperative frameworks to foster meaningful change. Meg is particularly interested in the intricate intersections of substance use and gendered violence, a focus that aligns with her current thesis work on parallel systems of oppression, starting with international drug policy. Courtney Lecanto is the Specialist Family Violence Advisor in Mental Health at Bendigo Health. So Courtney Lecanto is a social worker and has spent her career specialising in family violence. She has recently led the statewide coordination of Specialist Family Violence Advisors in Mental Health and is also a Specialist Family Violence Advisor in Mental Health at Bendigo Health. She brings over 16 years of experience across healthcare, mental health, tertiary education, the courts, and family violence, with a strong focus on rural and regional mental health, and working across the developmental lifespan. Courtney works from an intersectional and response-based practice focus. And lastly, but not least, we have David Cook, who is Senior Manager for Youth, Family and Carer Wellbeing at Access Health and Community. So David is trained in social work and has worked in Australia and the UK in sectors such as child protection, education, family services, family mediation, counselling, mental health and elder abuse. David is the Child Safety Officer at Access Health and Community, Chair of Wurundjara Family Violence Network, Chair of the Inner East Family Services Alliance Operations Group, and has led the implementation of MARAM information sharing across Access Health and Community. So each panelist today will respond to a mix of general and case-specific questions, which will explore how to build trust while fulfilling information sharing obligations, what effective collaboration looks like across care teams, how to navigate confidentiality and consent when working with children, what purposeful information sharing looks like in practice, as well as how to ensure children's voices are heard and acted upon. We encourage you to use the question and answer box to share your reflections or ask questions throughout the discussion. Please note that this is a space for learning, connection, and strengthening our practice together. All right, so we might get started with our facilitated question and answer session. So we'll start with the question for everyone, if that's okay. So please feel free to jump in. How do your responsibilities 5 and 6 support more coordinated and effective responses across care teams? And what challenges have you encountered in applying them? Anyone can go first.
I'll jump in and go first. And then, yes, feel free to cut me off or stop me talking, Court and David. I could take up the entire 45 minutes that we have left. My lens on thinking about how substance use interacts with the experience of and the perpetration and use of family violence. One of the things that we really experience from the AUD sector very broadly is an experience of stigma around substance use and substance use seen as a moral failing. So what we often find through secondary consultations or through the information sharing scheme, as well as in responsibilities 9 and 10 in collaborative risk management, is a position of risk based on substance type, not on the behaviours associated with the use. So in Hayley's experience, we can see that when dad drinks, he becomes more aggressive and he yells. It's really great to highlight those behaviours, very good to highlight those behaviours in the context of risk relevancy and in information sharing. But sometimes it can be really difficult in collaborative risk management meetings and in that collaborative risk management environment, unpicking what behaviours are associated with family violence, what behaviours are escalating when family violence is occurring and someone is using alcohol as well, and being mindful of the interrelation of risk between substance use and family violence. We know that 67% of homicides were perpetrated by someone who was substance affected at the time. Intimate partner homicides, 2/3. We know that in 80% of homicide suicides, the perpetrator was substance affected at the time. So we know that substance use increases the severity and frequency of family violence, but we're really interested in the behaviours associated with that substance use, or the alcohol use, which is the most common type of substance that's used. And so one of the things really broadly around a secondary consultation is asking the AUD practitioner what behaviours they might see from a de-identified secondary consultation that might be associated with substance use, and how possibly a reduction in that substance use might also reduce risk.
I think building on that too, Meg, you were sort of saying, I guess, into that interrelationship as well. I think in different ways, but I guess in mental health, particularly in public mental health, we're really mindful, I guess, of the acuity of the impacts of family violence on somebody's mental health. I was thinking about this case study because we have, 3 family members here. We have mum, dad, and Hayley. And centering for Hayley, there could be potential, I guess, interrelationships at any point with any of those family members with mental health, and depending on which part of the mental health service system. I think I'm really mindful that I think some of the challenges and the impacts of family violence on people's mental health, it doesn't get pathologized. So I think we can be sitting with that and be really curious when we work with different services around what that kind of looks like. So picking up and actually having some visibility, Meg, as you're saying about the specific behaviours, but actually what is it that we're seeing, or what are services seeing that they are concerned about? Because I think mental health is definitely one of those terms that doesn't benefit from people kind of using generalised statements such as there's mental health concerns, or, there's impacts on mental health. Okay, so what does that look like? What does that look like for Hayley? What does that look like for mum? If you're curious about whether dad has had contact with a mental health service, why are you curious about that? What are you thinking? So actually, in terms of seeking secondary consults or in sharing information, seeking, or even again, as sort of those deeper relationships across the sectors, we can be quite specific, and I think there's quite a value in supporting staff across different service sectors in documenting their observations and in documenting the behaviours that they are concerned about. So they were some of the things I think I was thinking about in relation to this when you're thinking about responsibilities 5 and 6 there.
And for me, I guess, just listening to Meg and Courtney just now, one of the biggest challenges can also be one of our key benefits in terms of these aspects of the MARAM responsibilities. We all come from different sectors, we have different focus, we have different clients, but we all have the same desire to reduce family violence. And so as long as we learn to trust and respect our differences and our relevant expertise, then we can work better together. I think a challenge comes where there's an us and them amongst the service sector, and frustrations. Like, we all work really hard, we all have challenges around funding and requirements of our programs, and when you're not in someone else's program, that can be really frustrating when you assume that they can do something or be able to take something on. So I think for me, that's the biggest challenge, is to get over yourself a little bit, and listen and respect the others, and seek the expertise of other sectors, and be willing to engage in conversation rather than have that us and them, because we're all in it for the best interests of Hayley and her family here.
Absolutely. Thank you all. That was a wonderful start to today's conversation. Courtney, I might ask you the next question, which looks at what strategies may help to build and maintain trust with clients while also fulfilling obligations under the information sharing schemes. Also noting that you probably have a whole bunch of other legislation that you need to be considerate of in your practice space. So how you're working around that as well.
I think it actually builds on really what you were talking about there, David, in response to this. So part of what we don't always do particularly well sometimes, and we can out ourselves as a service sector here, we don't always, when you come from big service sectors, always have a consistent level of professional humility and practice humility. We in public mental health, you work as part of large hospital-based organisations. You can have hundreds of colleagues, if not sometimes thousands, depending on the size of your workforce. You can work within a medical model, you work within treating teams, with psychiatry and people who have a level of expertise. And so I think sometimes that can be really tricky when we then are balancing seen really big service systems with particular cultures that can sometimes be there. And we've had a Royal Commission into Mental Health Services in Victoria for a reason. So we balance that. But then bringing in these relationships and this opportunity for culture to be built around professional humility, I think that supports staff and clinicians to be engaging with a level of position of curiosity than when they're working with people. And, you know, we would support that from mental health in terms of a position of curiosity and maintaining that as part of motivational interviewing techniques. So when you are directly engaging with clients and consumers, and that's language of mental health that we sometimes use, I think that really helps, but it also then goes hand in hand with then that level of professional humility. So when you are working with services and thinking, okay, who else do we need to talk to about this? Who else isn't part of the picture? Really maintaining that we are where we can be a very big service system, and we can be very specific to different points in people's lives. Sometimes we are the only service system at times as well, and then bringing others into it is incredibly important. But to do that, you also, again, have to maintain this level of humility and going, well, who else needs to be part of this conversation? And what does that look like for my clients to be doing that work? I think then thinking through specifically to mental health as well, we obviously are covered under the Family Violence Protection Act in terms of information sharing. We're part of that intermediate workforce more broadly, a level of assessment, but we do have the Mental Health and Wellbeing Act in 2022 that has had, I guess, an opportunity for lots of shifts around some of how we do business. But this also then means that there's levels of complexity. So things like if people are on treatment orders and the Mental Health Tribunal and what information actually people have the right to have given to them as part of those processes, that means our service sectors have to think quite carefully about how we document family violence, what that looks like, and also what our service sectors are thinking about in terms of their, I guess, processes around doing this work. So I think that's one of those complexities sometimes external services don't always necessarily sit with. And the other thing that can be there as part of that is external service sectors, I guess, who specialise in family violence, their potential assumptions maybe about where different really health-based services, including public mental health, are up to in their MARAM alignment. So sort of those expectations that service systems definitely got this level of assessment embedded into their services. Some of that will be very varied depending on the size and depending on where service structures are sitting. So I think, again, just being curious around that and checking ourselves rather than kind of making this assumption that we know, because actually part of what I encourage our staff to think about is how do we know what we know, and how we actually informed ourselves about that.
I love that. I love how do we know what we know? I think that's a great question to ask, not only in this space, but in most spaces that we work in beyond working with clients. Just thinking about the curiosity that we hold as well. So love that answer. Thanks, Courtney. I might go back to David for our next question because we're having that broader conversation around professional humility and that shared understanding across services. So thinking about what helps or hinders consistent information sharing and collaboration between your services and others in the care team. I know we've had some of those themes already cross into some answers today, but if you have any further things to add around that.
First of all, I also think curiosity and humility are great bases for this conversation, if we keep that in mind. What helps or hinders consistent information sharing? There's so many different things that help or hinder organisational policies and approaches, the training that's provided across the different organisations, the level of expertise and experience. So there's sectors now that are involved in information sharing and family violence that have never been involved before. And so there's a lot of nervousness and hesitancy and, oh, that's not my business and I don't know what to do here. I might make things worse. There's all that sort of conversation. And there's a bunch of older people like myself who there's been a whole switch in approach to what's important. The focus now is obviously erring on the side of safety of victim survivors. When I was going through training, it was confidentiality was the god and the most important thing. And so that's a real flip for a lot of people. And I don't think we're there yet. I think we're still working through that shift in mindset. And so for some sectors who have sort of come out in first or second tranche of MARAM and information sharing, they've been at it for a few years now. And then there's the other sectors like education and so forth that are much more recent and still coming to terms with where they fit in the system or what their responsibilities are. So I think we need to recognise that when we're setting up care team meetings and when we're having conversations with other sectors and other people in the situation, recognising we might be at different places and have had different experiences. So that you need to keep that in mind when you're working out how you're respecting the other person, how you're communicating with the other person in the sector, let alone the clients. Just working within the sectors is you need to tread carefully and lightly and not come in being overbearing and I'm the expert, you'll do as I say. That doesn't work.
Absolutely. Thank you for sharing, David. That's a great segue into our next question, which is looking at what does effective collaboration look like in your specific context. So I might direct this one to Meg. So in the AOD context, and how can care teams move toward moving more consistent and purposeful information sharing?
Thanks, Em. And I think just again, building on everything that David and Cord have said, that, collaboration takes work. And when we get really busy and we're very responsive to the demands of our core function and our job, it's really easy to dismiss opportunities for secondary consultation or networking and building relationships with your colleagues across sector. But that is a key component at a systems level of supporting your client. You might not think that it is, because all client contact is, it's the key, it's what we get out of bed for. But knowing some really helpful folk in different sectors absolutely benefits your client at the end of the day. Having effective collaborative relationships with folk outside of your sector, building their confidence in you, in understanding and assessing family violence risk within your context is an incredibly helpful thing to do. So we have in alcohol and other drug sector, we have risk relevant indicators specific to substance use, which we identify in our risk assessments. So our alcohol and drug risk assessments, our risk assessments, very brief risk assessments on mental health as a component of those AOD assessments, as well as family violence risk as a component of those AOD assessments. And so we're really able to identify how substance use is weaponized in the context of family violence. And if we want to share that information, it's really important to have collegiate collaborative relationships across sector, because folk in our sector know that too. They know that risk relevant context of substance use exploitation, but it's often folk outside of our sector. So what are we doing to support those collaborative relationships at a practice level? But more importantly, what are our leaders doing at a leadership level to support systems alignment across sector? If you're having trouble connecting in with a practitioner, there's a whole range of reasons why practitioners are not responsive, and it's most likely because they are in and amongst it, they are busy responding to the everyday needs of their role. It's really up to our leaders to connect in with folk in those sectors and to establish collaborative relationships as well. It's not just a this is important in the moment, I'm going to do this right now. It's a consistent, routine, reliable thing. And once we're consistent in our collaboration at all levels, from practice all the way through our systems, then we can begin to be really proactive around how we collaborate and when we collaborate, rather than reactive. Of course, reactive collaboration is really important, but to be proactive, to manage those relationships, creates a responsivity in our demands and in our needs to support the client in that moment, that we can only get through established relationships. And finally, I think speaking in terms of risk relevance and centering the family, and in this case, centering Hayley in all of our conversations is the key. We've got a really common purpose, as David mentioned, really common focus. How can we provide our shared expertise across each identity, how each identity is being weaponized within our area of focus to support and center the needs of the family in our care.
Thanks, Meg. That was really great and a beautiful way to finish around centering the family and the child. I think that so often gets obscured by all the little things that we need to do in each of our roles. So really coming back to that main point of why we're actually doing this, and it's for the child, it's for the family. So thank you for sharing. Before we move on to the more specific case scenario questions about Hayley and her family, we might just finish up with a question for everyone to respond to. How fun. So how can we strengthen coordinated support networks to empower children and ensure their long-term safety? We've talked a lot about challenges, what we might see as barriers in our day-to-day practice with information sharing, but let's take a more strengths-based focus for the time being and think about how we can strengthen those support networks. Anyone can go first. I will pick on Meg. Thanks, Meg.
I went first last time, so I was trying to be thoughtful. Sorry. There's a lot that we can do to strengthen the child focus and to strengthen collaboration. I think if we all come from a place of humility, as has been said before, we center the needs and the goals in a system of equity. Not everyone, as everyone here knows, not everyone that we work with wants the same thing. So being really clear on what someone wants, what our likelihood of achieving that is, what the expectations we hold of other service sectors are, and then working together to create as many opportunities as we possibly can to achieve those goals and those outcomes. I think the AOD sector do this really well. I think we consistently meet people where they're at. We don't hold expectations outside of what the young person or the adult in our care wants. We meet them where they're at. And then I suppose when we're thinking about the AOD sector specifically, we are empowered by our harm minimisation framework, our national framework to reduce harm, which is essentially safety planning at every point. But thinking about the harm minimisation framework at a systems level, it really enables us to be compassionate and non-judgmental and work to meet people, again, where they're at. So other systems that hold policies such as abstinence policies aren't capable of meeting people where they're at and meeting them, helping them to achieve their goals because there are frameworks in their way. One of the real challenges for us as a service system really broadly is that we're all broken down into identity, into intersectional identity. So we've got substance use. Court has mental health experiences. David really has everything within the community health, but specifically, young person. Family violence have family violence experiences, sexual assault have sexual assault experiences, homelessness have housing need and homelessness experiences. But the person that we get out of bed for is a whole and complex human. They're whole. They're actually not even complex. We just say complex because our service systems are so individual, are so identity-based. We make it complex. So how we can meet someone as a whole human where they're at, meet their need without having for them to go in a very traumatizing way from service to service to service to sector to sector to sector. I know we talk a lot about being trauma informed, but if we think about our systems, are they actually trauma informed? Thinking specifically about alcohol and other drugs, we ask for an alcohol and drug assessment every 3 months when someone's going into rehab, or every 6 months. That's a 2-hour assessment every 3 months, asking the same questions. That's not trauma informed. That's not trauma aware. And that's certainly not the end goal of healing informed. So how are our systems enabling us to strengthen our collaboration and our focus on the people in our care is my question, I suppose. Yeah.
And I would say, actually building on that too, though, we need to be able to be questioning our service sectors. Like, I think sometimes it can feel, you know, we're all even getting recorded today. We show up, we do a panel, and it can feel, you know, it's always a little intimidating when you actually have to say, hey, how do we turn the lens on ourselves here? You know, and that can be quite this frank and fearless kind of frame that you have to lead with, and balance then with going, actually, and then there's some wonderful movements, and then there's some wonderful kind of positive aspects that our service sectors bring. But you do have to be thoughtful around it. Like, that practice humility has to then center to actually questioning our service structures, and then actually, are they serving the people how we want them to be serving? And a lot of the time we can't necessarily change that in an individual way, but I certainly think we can own some of those challenges, so that when we're actually coming together, I guess, with other, I guess, sectors, but in a networked way for specific reasons, we can offer that. You know, we don't necessarily have to hide behind that. We haven't created these structures. So it's okay if we can actually be naming some of the challenges, particularly if it will help manage people's expectations in a really honest way that will build trust, because then it will help people, and it will help, you know, you think of Hayley and her family in this journey here. If you didn't know, I guess, kind of the service system potential limitations, or, you know, the level of acuity potentially that might have to get reached before somebody could even access potential mental health support from public mental health, it's very easy to kind of misread that and have then a level of frustration at other service sectors. So I think actually having that capacity to be questioning it. It also means too that when you're coming together in care team meetings, or you're meeting together as professionals, that some of those things can be sorted through more quickly and more efficiently. Watching people sort of, particularly doing case management where they have to make multiple phone calls, that's part of it sometimes, but actually getting together in a professionals meeting, it can be short and sharp, can be, you know, 15 minutes, 20 minutes, half an hour, whatever you have to give. You know, you can tell people that. It's certainly far more efficient to have people then sharing information in a dynamic way. And I think that's part of it, as you move through sort of your service system maturities in embedding information sharing schemes, is you then go, okay, well, we can do this in a dynamic way now. We can be very responsive. We can actually, you know, share this. We know this, and we can share this. And I think that really helps build trust. But I also think it helps build much more effective outcomes with clients as well.
Courtney. David?
Yeah, so I really like what Meg was saying about building relationships with other sectors and other people before you need them in a crisis. Like, that's what we do with safety planning. You do it before the crisis hits. So in a crisis, you know what you're doing. I heard a story about if some random person came up to you in the street and said, "Can I borrow your car?" You're going to go, "Hang on, why would I give you my car? I don't know you, I don't trust you." But if it's a friend that you know and trust comes up and says, "There's a crisis, can I borrow your car?" then you're going to be able to do it without thinking. So that's that building relationships before you need them. And in terms of, and I'm coming from a place of family services, which we're sort of funded to do care planning and coordinated care and case planning meetings and so forth, and some sectors aren't. But the Royal Commission into family violence highlighted that a key aspect was that lots of people had lots of bits of information, but not many people had all the information to make the appropriate assessment, to make the appropriate planning for families. So it really is important that we all have the right information, that we're not, it's that whole, if you have 8 people touching an elephant, they're all going to describe a different beast. We all need to have all the information that's relevant when we're making assessments, when we're making planning, care planning meetings, and what we're going to do for that client. But there are challenges with that, especially it's becoming more and more so that a lot of sectors, a lot of people aren't funded for that collaboration, that care coordination. So we need to advocate at a system level, at a funding level, Our sectors need to advocate for that. NDIS doesn't fund for that care coordination generally. So how do you get somebody that's involved with the family to come to a case planning meeting when they're not funded, when you're funded fee for service or whatever? So there are some real challenges around that, but it's really important that we continue to fight for that and work towards that and trust the people that we're getting in the room before we get them in the room.
Absolutely. Thanks, David. Meg?
Yes, I just want to add to that. Such a great point around role expectations. I think that one of the challenges we have in AOD is because we have reasonably flexible client contact timings, we have the capacity to transport clients. So one of the things we find the AOD role and function in care coordination or collaborative risk management meetings is for the AOD worker to transport the client to the meeting, not see the AOD worker with the value that they hold on the expertise around how substance use is being exploited in that context. And so I think absolutely understanding what the role and capacity is of that individual and how they can benefit collaborative risk management, and absolutely getting the client there is a really important part, but how they can build that into their normal service contact rather than possibly making an extra trip, how we can be really thoughtful and really clever around how we use our time with clients. While we're talking about roles, just to flag, AOD is one of those services that is not funded for collaborative risk management. All of our funding is based on client contact, client time. And so we have a little bit of extra funding. We apply through different means if we have anything at all come up around family violence, but it's not always possible for an AOD clinician to attend a 60-minute collaborative risk management meeting because that gets directly taken out of the client time. So in a 4-hour client window of standard counselling, if an hour of that is spent with professionals, then there's only 3/4 of time left with the actual addressing of substance related harm. So being really thoughtful around what other sectors' constraints might be and how we can use some of the strengths of different sectors to support better outcomes for the client, because everyone's there for the client. So how we can make all of that happen collectively. And sometimes, just to flag, you might need a navigator to support that process. And I can see, shout out to Janica in this session. Janica is a specialist family violence advisor in alcohol and other drugs based in very rural and remote regions. And so sometimes Janica will be driving for 3 hours between services just to do secondary consultations and to support the AOD sector. So sometimes, there are real barriers to collaborating and to accessing different types and areas of expertise because of that distance. But if you have an opportunity, we have 22 specialist family violence advisors in alcohol and other drugs, and Court is one of the 26 specialist family violence advisors in mental health. And reach out if you're wanting to navigate the mental health system or the AOD sector. Please reach out to the advisor in your region.
Great, thank you so much, Meg. And we will put a link to that with the resources that we send out with the webinar recording. So thank you for flagging that, very useful. We might move on to some more specific case scenario questions. So really thinking about Hayley and her family situation in this case. Another question for you all. We might start with David this time. So going bottom up on my screen. But the first question is, what key information about Hayley's family situation should be shared among agencies involved in her care? And how do we determine what is appropriate to share?
So, first of all, it depends who you're sharing with and under what information sharing scheme and for what purpose. So it needs to be purposeful. It's not just gossip or telling the whole story. It's working out, are you sharing information for an assessment? Are you sharing information about ongoing management? And how does it relate to, in family violence, the risk and the protection? And in child information sharing scheme, how does it relate to the well-being of the child and the future ongoing well-being of the child. So all of those things need to be taken into consideration when determining what you're sharing, how you're sharing, who you're sharing to. And it can get quite complex as to what's appropriate, what's not appropriate. As I mentioned before, I'd be erring on the side of safety of victim survivors rather than confidentiality, because you want to go that way. You want to make sure there's safety first, but you do need to be purposeful in the thought and the practice and about what you're sharing. Have a consideration. Talk to your managers or your experts in your organisation to work out what's appropriate. So that's the start of the conversation, I guess.
Thanks, David. Courtney or Meg?
Meg, you're on mute if you're talking. Do you want me to go? All right. So I think picking up on, I guess, what you're sort of saying there, David, too, I think you have to be specific at the start, and thinking through in regards to this case scenario, there will be obviously some child wellbeing concerns is kind of that broader CISS framework. However, I think we can also then be safely going, we're identifying some concerns around the use of family violence here from Dad, from Hayley's father in terms of his behaviours. So then if we're using the family violence information sharing scheme, what would we like to, I guess, seek? And then also what would we like to proactively share? And we should be doing both. And sometimes we might actually want to do some information sharing scheme requests first, initially to service sectors to see what is known or not known. And in this case, I guess I'd be thinking through if your organisation is an ISE or if it is an RAE, you might be looking for some different things. But I would be encouraging services to be undertaking some information sharing scheme requests about this initially, particularly to with a bit of a developmental lifespan here, is if Hayley is your client and you're identifying some of the specific impacts of family violence that are impacting on Hayley's mental health. Are you interested, I guess, about what service sectors know about that? Are you interested if Hayley, for example, has been referred or has accessed any specific mental health supports previously? Is she currently working with any services? That's always an interesting one, I think, for services to consider, that they might know that, but actually, do they know that? And then also, are we then seeking information about mum as a victim survivor? If so, do we have consent for that? Or actually, are we seeking information then about Dad and what service sectors know about Dad? And I guess, again, we're really mindful that we, as a service sector in mental health, we could potentially be working with Dad due to, potential things that he's had going on for him with his mental health, but also we will be really clear that we don't invite a level of pathology attached to Dad's behaviour. So this is where I think being mindful that as service sectors, if we were to provide information, if Dad has, for example, even just had a phone call that, Dad made to, for example, our triage services at some point. Perhaps it was a phone call that he himself made at some point, or even if he'd been working with a GP and they had made it. There might be limited information around Dad known to a mental health service system, because there might not have been a level of acuity that Dad has indicated, in terms of what he's presented to service systems with. So I think we would be mindful then of, if we were then to provide information back, that we then wouldn't attach Dad's use of family violence as a causal factor, a causal factor due to his mental health or his mental state. So I think we can be really clear around that, and we can be clear about then in our framing around that too. So they would be some of the things, I guess, in this specific circumstances that I would be interested in. And I guess we're also really mindful too that mum, because of the impacts of family violence, may have some things going on for her around her mental health, again, because of the impacts of family violence. Does not mean that mum doesn't get a service system response, but we can actually see it due to, I guess, the impacts of Dad's behaviour and the disruption that does to people. So I think we can start to peel it apart so that we haven't inadvertently sort of neutralized it and sort of put some weird labeling on it about, you know, dynamics or relationships or marital issues. I think, again, thinking through how we frame the impacts of dad's use of family violence, that can be very powerful in starting that from information sharing scheme requests, in actually then supporting what we know about the family.
Thanks. And I might just build on that, Court and David. I think you've provided such an extraordinary foundation, really, for me to step into substance use specifically. But David, thinking about legislation is really important, because we know some of the information that we will share with services like child protection will be court reported. And so how we use legislation can also protect our service system from having that information shared. For example, under the Family Violence Information Sharing Scheme, it's a good one to use. One of the things that we're really discovering, and this is with Emma, Court, and I, and you know, and David, and every service system, as we develop a more robust understanding of family violence and how it presents in our sectors, we're being much more discerning around what risk actually looks like. So we've got all of our standardized risk under the MARAM, that's all detailed there. But when we think about mental health, Court's just detailed some really specific indicators that mental health might be weaponized or justified in the context of family violence. We have the same kind of thing in the AUD sector when substance use is present. And so it's trying to understand substance use as an experience of family violence, or as a risk factor in increasing the severity and frequency of family violence. So I'm just going to put in the chat just some of our risk relevant indicators that we've identified in substance use. So if you're doing an information sharing request, these might be some of the indicators that you're looking for, some of the information that you're seeking. And what this does is it helps us provide more context specific, much like Court and David have done with their sectors and their experiences of substance use, and how substance use might be increasing risk or impacting safety. We already know through the case study that there is the potential for dad to engage around AUD treatment. We know that substance use increases the severity and the frequency of his use of violence, including throwing things, verbally abused, being verbally abusive, being aggressive, being being really scary for Hayley. There's lots of things we could do in AOD to support him, address his substance use, but we really need to work with him to figure out what might be driving his substance use. And I think it's pretty clear from the case study that this is a man that's under significant strain, financial strain. The case study doesn't say if mum is employed, but on the assumption that she's not, and that he's the primary financial provider, and they live on a farm. We know how precarious farming can be, that the entire family, that also creates a barrier for mum and for Hayley in accessing safety and support, because their financial stability is connected to his, increasing his power and control over them. Substance use, alcohol, to buy alcohol, it's also expensive. So using your finances to purchase alcohol and to consume alcohol is an interesting choice when financial strain is so significant. But we also know, because it's a dairy, that there's the likelihood of weapons as well. So considering all of the risk indicators present in this case study, and how substance use is acting as an amplifier of the perpetration of family violence, an amplifier of risk, here it's like a gasoline on a fire. There's lots of options. We could explore pharmacotherapy with him if he was interested. Could get him on some medication for alcohol use, really strong and great outcomes on pharmacotherapy for people who are alcohol dependent. We're also possibly looking at additional risks around alcohol withdrawal. So we really want to engage with the AOD sector and find out what those risks might be, how his substance use affects the functioning of the family, as Court mentioned, and then also what opportunities there are to disrupt his use of violence. If they are solely financially dependent on him, then their situation is quite different to someone who might have full-time employment and might have financial means on their own. So really unpicking and exploring how that substance use and that dependency of mum and Hayley on dad and his substance use is a really important, they're all really important risk relevant indicators to understand, not only for safety planning, but also for predicting a possible escalation in family violence risk.
Absolutely. Thanks, Meg, and thanks, Courtney and David. I think you gave all great perspectives from your context around that question, so I really appreciate it. Just conscious of time, we do have 5 minutes remaining, so I'll do one last question to wrap us up. And once again, you're all welcome to answer it if you'd like. But that is, what protocols or systems can support timely and consistent sharing of information to prevent critical details from being overlooked? And we might start with Courtney, if that's okay.
Absolutely. So in mental health, a lot of the time, like I said, because in public mental health, we will be attached to large health-based services and hospitals. So there will be a lot of the time a centralized information sharing scheme process, so that there will be one email address that people can then seek information from that might go through our health information services and then get designated down to different clinical and treating areas. From that, that's kind of an official process that absolutely allows for it to be monitored, it to be then, I guess, documented and recorded, so that we're not then relying on individual relationships. So it's a great starting point for external services. But then flipping that as well is actually then, how do we respond to dynamic risk? So this is where services being really clear that if they are urgently seeking information, going, we know actually there's a person using family violence who's just accessed your potential ED and is having an assessment with your ECAT. Okay, what does that look like then? Do you want to actually try the centralized information sharing scheme? Maybe. Or actually, do you want to then be contacting another point within the service sector to be making those inquiries? And being really clear about, if you are seeking something urgently, why are you seeking it? So that, again, service sectors can have a level of responsiveness to dynamic and live risk there.
Thanks, Courtney. Meg or David?
Oh, you are so polite, Meg. The interesting thing for me here is what can support timely and consistent information sharing. In some ways, they contradict each other, because if you've got a system that allows a timely response, basically, which means it's disseminated amongst staff that they can respond immediately, you're then potentially not going to have the consistent response. Whereas if you have the central point of contact, you're going to ensure a consistent response. So there has to be a balance there. And you have to work out, as Courtney said, whether it's an urgent, immediate need, or whether it can be done 24 hours, 48 hours, whatever it is. So yeah, there's a real balance there that potentially, if you don't get it right, can cause some challenges for the organisation or for the systems that you've got. And I think it was brought in, the information sharing schemes ideally were brought in so that you could have a quick response, but it hasn't necessarily worked out that way. The Eastern Metropolitan Regional Family Violence Partnership has done a recent review into policies and procedures of organisations in the Eastern region and what their information sharing scheme policies look like. And it varies from a single page in some organisations to 45-page documents in other organisations. So there isn't consistency. And you can see that tension where different organisations are balancing up consistency versus timely response. I haven't got an answer to that, but it's certainly something that's a challenge.
Thanks, David. Meg?
Finish on those extraordinary points by saying that the information sharing scheme is such an incredible resource for us in community. It's changed the way that we work, and it's extraordinary in every way, in almost every way. One of the things that I think we can do better moving forward as a homogenous group, really, of responders in ISEs is to center the dignity of information. So ask risk relevant information per sector, center only the absolutely required information, not inhibiting any information sharing. Of course, it's very important, but being intentional and incredibly thoughtful about the information that we are sharing. It's not just an information dump. We're very purposeful in the information that we share, because we said to the dignity of that information and the information we're sharing.
Thanks, Meg. Appreciate it. That's a great point to finish on. So bear with me as I share my screen one last time. So thank you for joining us all today for the third session of our Centering the Child series. We hope today's discussion has deepened your understanding of how to embed child-focused information sharing into collaborative practice and how the MARAM Responsibilities 5 and 6 can support safer, more coordinated responses for children and families. So as you can see on the screen, there is a QR code. So we do encourage you to take a moment to complete the post-session survey. Your feedback will help us to improve future sessions and ensure the content remains relevant and impactful. So just some final next steps before closing. So the session recording will be shared with you at a later date, as well as all relevant resources that were mentioned today. You can stay tuned for the final session in the series, which is occurring on Wednesday, 5th of November, and that will explore working collaboratively with children, young people and their families. Lastly but not least, if you have any questions or would like to follow up, please feel free to contact me directly. Thank you all again for joining us today. Please send a virtual round of applause to all our wonderful panelists to thank them for their time and expertise, and we'll hopefully see you at the next session. Thanks all.